We'll go through this pretty quick, but I'm going to give the con argument. And again, one of the things that we were told to do was, should every patient receive neoadjuvant chemotherapy prior to cystectomy? So don't look at the poison box there, but let's keep moving. So my goals are pretty simple. I'm going to say that it's not appropriate or necessary for all patients who undergo radical cystectomy, but rather favor a more selective approach, avoiding unnecessary delay for potentially ineffective or toxic therapy in some circumstances, and then allowing for them to receive therapy after the fact based on their pathology. So these are the 4 bullet points: evidence, which has somewhat been covered, patient factors, toxicity, and a more selective approach that I'll lobby for. So no one can dispute that there's level 1 evidence for neoadjuvant chemotherapy. He's already well described it, and he was an author, 8710. We all drink from the Kool-Aid that this provided benefit for patients that were eligible to enroll in the study, and the benefit was for all of the patients that were in there, and this is the curve that's similar to what he just showed. But if you really break it down, those top 3 lines are muscle-invasive with or without, and T3 without, and they're pretty clustered, and the biggest benefit really was in the T3, T4 patients, where there was a difference of 65 versus 24 months. So although there may have been a benefit overall in the study, the biggest benefit, the biggest bang for your buck is in the truly locally advanced patient. I'll just say here that meta-analysis, as shown, did demonstrate, but there's a difference between the overall risk reduction and the absolute benefit. And the absolute benefit for all this stuff put in the blender in a meta-analysis is probably 5 to 7% in terms of recurrence-free survival. So 5 to 7% all comers. This is the meta-analysis. There's no substitute for platinum, and so that's emphasized because a lot of patients in the real world don't get platinum-based neoadjuvant chemotherapy. They get something less. And I think that anybody who has seen what was just stated knows that less than platinum is probably not going to be translatable to the same outcome. Now here's the problem. Not all patients are eligible for neoadjuvant therapy. Up to 50% of patients are ineligible because of a variety of factors: poor performance status, impaired renal function, comorbidities, and a lot of other factors that are hard to measure, like patient won't accept it. But not all patients qualify, so despite level 1 evidence, we have a problem. Impaired renal function, some masters of chemotherapy can get them through when their GFR is, say, in that 50 to 60 range, maybe even down to 40. But at most places, if their eGFR is less than 60 mLs per minute, they're not going to give them platinum, so you're not going to get the right therapy. Not everybody comes in as healthy as patients on clinical trials, and that happens to be very common in bladder, especially invasive, heart disease, neuropathy, and hearing loss. We're having all these patients tested for hearing, and when they have a hearing loss, they avoid platinum, and they can't get what would be recommended in the guidelines. So we agree that neoadjuvant is recommended for invasive tumors, and it always should be platinum if it's given, that it's not recommended when there's a contraindication such as poor renal function, and in the case of progression, so they need a little snapshot while they're getting neoadjuvant, that also would be an indicator to switch horses and go to cystectomy or even switch chemotherapies. The guidelines support the avoidance of carboplatinum, which was commonly used by many and may still be in the United States. I don't know if there's any snapshot data on that. Patients ineligible for neoadjuvant-based chemotherapy should proceed with definitive surgery and then look at the pathology to determine. These are just some things that were percolating out there, but not all tumors respond to neoadjuvant chemotherapy. Clearly, we don't have a cure for this cancer with this therapy. It's not like germ cell tumor. There's a couple of data that's been gleaned from the genetic analysis of these tumors and these molecular subtypes. Some just resist platinum altogether, and a recent study that's shown here showed that primary tumors respond better than those that are secondary, so those that emerged perhaps from BCG failed patients. So there's big differences in the tumor ability to respond to that, which is really poorly understood at this point in time. Again, a selective approach. Can we identify those who might do better with neoadjuvant and those who should go on? This is data or study and kind of a conceptual report from the MD Anderson group, where they have divided patients based on clinical risk factors, and if you're high risk for recurrence versus low risk for recurrence, and then they use that as a arbitrator or a triage to allow them to get radical cystectomy if they're in the low-risk group, and if they're in the high-risk group, so they have lymphovascular invasion, locally advanced tumor, a blocked kidney, and some of the variant histologies, they might move them on to additional chemo prior to surgery. These are the composite guidelines for adjuvant chemotherapy, and we will talk about, show that, you know, all the studies that were done were very small studies, so collectively they don't pass the muster, but when they're pulled together in a meta-analysis format, there is some evidence to suggest that there is benefit to the use of adjuvant chemotherapy with about a 9% improvement in survival, and that's pretty similar to what we talked about with the neoadjuvant chemotherapy in terms of a risk reduction in absolute. Toxicity is acknowledged that these chemotherapeutic agents are toxic. Up to a third of patients may have grade 3 or grade 4 toxicity. Fortunately, in the studies that have been done, it didn't preclude the ability to go on to cystectomy in expert hands, but certainly it's out there. So the similar results, we don't avoid neoadjuvant chemotherapy because we think we can't take them to surgery, but it can complicate things when their platelet counts descend. They are at increased risk for thromboembolic phenomenon, et cetera. This is some snapshot of what was happening last time we calibrated this. There's probably some updated versions. Traction for neoadjuvant therapy is increasing, and that's a good news. But again, more than half of the patients in the real world do not receive neoadjuvant chemotherapy. Some, I'm sure, are due to the fact that they're not eligible for this type of therapy. So I've tried to show you the evidence, which is indisputable, that there is benefit to platinum-based chemo. There are patient factors that limit the ability, so not all patients can get this. There is toxicity. It's acceptable, but it is toxic. And a selective approach is perhaps more practical and feasible. So neoadjuvant therapy should not be offered to all patients with muscle-invasive disease. Low-risk patients should move on to cystectomy. Patients that are ineligible for platinum-based therapy should move on and avoid the neoadjuvant therapy. Adjuvant therapy is an option for patients, and although the data is not as robust, the decision is based on adverse pathologic features rather than just an upfront approach. So try to finish a little ahead of time to get us back on schedule. We really think the future of this selection process includes clinical factors as well as some molecular profiling of the tumors with proof that they'll respond to the various forms of therapy. Thank you for your attention.